colleagues, dear PGTs. Now we are going to resume our master class for the day. Now I request Dr. Apurva Kumar Mukherjee, who is one of our course directors, to introduce today's chairperson and also the subject. Over to Dr. Apurva Mukherjee.
Good morning, everybody. Good morning, my chairman of the ICP West Bengal, Dr. Amul Banerjee, and my co-directors. I sincerely welcome all the PGTs for this exciting master class, which is being taken by none other than Dr. Prantar Chakraborty, who is not only a very learned hematologist and hemato-oncologist, but he is a very humble and amicable personality, and he is going to mesmerize our students with the knowledge of paraproteinemia. His subject is paraproteinemia. As we all know, that over the last 2-3 decades, there are a lot of understanding changes and changes in identifying so many different disorders associated with late B-cell lymphocyte lineage. And we all know that paraproteinemias are also have got different synonyms like dysproteinemia, plasma cell dyscrasia, and the monoclonal gammopathies. And we do also used to encounter and still find multiple myeloma, primary amyloidosis. These are all very overlapping conditions. And to enlighten us, there is not only Prantar, but the chairperson of today's session is none other than Dr. Madhuchanda Kaur, who is the chief of hematology at Peerless Hospital, Kolkata. Without standing between our PGTs who are eager to learn, and they will have a lot of queries and questions to our learned chairpersons and speaker, I request our beloved chairperson, Dr. Madhuchanda Kaur, to start the proceedings. Madhuchanda, please. Madhuchanda, are you there?
Hello, am I audible?
Yes, you are audible and visible.
Okay. Good afternoon. Good afternoon. Sorry, good morning. It's really exciting, the introduction given by Apurva Das, and it is really worthy because paraproteins are one of the most exciting fields in clinical medicine. What is just a few words on it? Paraproteins or monoclonal gammopathy is a protein or a light chain produced due to the clonal proliferation of mature B cells. Most of the mature B cells are the plasma or in the green. To those who are not very well versed with the history of paraproteinemia, two names are very, very important. One name is Henry Jones, who was a pathologist, and in 1847, early 47, he identified something that we call Benz-Jones protein. But it was 17 years later that he understood what this Benz-Jones protein was. And another very important doyen in the field of paraproteinemia was Dr. Robert Kyle. His really very exciting the postgraduate because he spent 60 years just looking into the archived blood samples in Mayo Clinic and saw that various background did produce paraproteinemia. And that is how he identified the different spectra of paraproteinemia. I think paraprotein is a marker, is a biomarker that has really stood the test of its time. Many biomarkers have become oblivious. They have become oblivious because they do not have relevance now. But paraprotein, 200 years has gone, but it has still stood the test of time. How has it stood the test of time? This is because it has continued to reinvent itself. We began with electrophoresis and we gradually moved on to more sensitive methods like the immunoassay methods. And that is how serum-free light chain has been detected as more sensitive for both diagnosis and for monitoring of the disease. Not only so, I think it is very, very interesting for the postgraduates that we have identified minimal residual disease in myeloma by certain methods like mass spectrometry, flow cytometry. 40 years ago, I think we had a better description of paraprotein than we had when we had Benz-Jones. But all this journey has been rejuvenated by the discovery of serum-free light chain in non-secretory myeloma as early as in 2001. So we have a huge spectrum. We have MGUS, we have asymptomatic myeloma, we have smoldering myeloma, we have symptomatic myeloma, we have amyloidosis, we have paraproteinemia with neuropathies, and these neuropathies are really a learning curve because we are continuously discovering more and more neuropathies with monoclonal gammopathies. A very, very interesting phenomenon is the newly discovered monoclonal gammopathies of renal significance. I'm sure Dr. Prantar is going to touch upon those also. We have learned about the biology of paraproteins, but we have also learned about the epidemiology of paraproteins. This is because we have found that certain ethnic population, like the African Americans, have more prevalence of paraproteins to the tune that globally, more than 50 years population, nearly 3.2% have got some form of paraprotein in their blood. So I think we are going to have a very, very good discussion by Prantar on this whole spectra of paraproteinemia. We had a simple picture many years ago. I think it was in 1800 something, 50s or something, where there was a picture of Sarah Newsbury. When she died, she had fracture of the humerus, of the femur, of the radius, of the ulna. And when on postmortem they looked at her bones, they saw that the bones were replaced by a tumor of the bone marrow. And that was called myeloma, because you know myelo is bone marrow. So that is how the name came. And this is a few words I put in, some brownie points, so that Prantar can have a very, very exciting deliberation of the next 1 hour. Over to Prantar for continuing this marvelous masterclass. Thank you.
Thank you, Madhuchandadi. It's always a pleasure to interact. I'll just start sharing my screen. One sec. So, yeah. I think my screen is visible, right?
Yes, Prantar, it is visible.
Slide share the slide.
Yes.
Share the slides.
So you're not seeing the slides?
You're seeing the slides, but slides skin is not
Share
shared.
mode, man.
Yeah.
Yeah.
Yes.
It takes some time.
Now
don't
it
worry.
is perfect.
Yeah. Thank you. Okay, so respected elders and my dear friends, thanks for this opportunity to discuss something which actually traverses all disciplines. So Madhuchandadi has already told you something about the history. If you want to read more, incidentally, this Henry Baines Jones, he was the first medical biochemist of the world. So he was called a chemical doctor, and in 1848, he discovered something in the urine of Mr. Bean, not this Mr. Bean. That was the name of the patient. And he suspected that there is something. He looked at it, heating it. It comes, it dissolves, it comes back at a later temperature. By that time, as our patients do, this patient also went to someone else. And then he ultimately died, and the post-mortem report, autopsy said that his bones were fragile and they had gone all breakage. And when he read that case report, he understood the relationship as to what he got in the urine of the patient and what happened to the patient. But obviously, he knew that there was something abnormal. And later on, we have understood that that was a paraprotein. And I think it's the first cancer biomarker in the world. So, Baines-Jones protein at that time has now been named as a paraprotein. When it is present in the blood, it is called paraproteinemia. But there are some synonyms like dysproteinemia, and then you also have something called monoclonal gammopathy. So it was very clear that this paraprotein, abnormal proteins, were being produced by a single clone of cells. Though I think in the last 5 to 6 years, we have understood there might be more than one clone. So sometimes what we are doing is we are removing this mono. So we are calling it clonal gammopathy. So it's all the same thing. I think monoclonal gammopathy sticks because all the nomenclature which have been built on the giants of shoulders, we call it MGUS, MGRS, MGCS, MGNS. So it still remains. So can any of the PGTs tell me what is going on here? This is a patient of myeloma who has this type of skin lesion. And I can tell you in blood, the paraprotein is IgG kappa. Any idea? What do you see? You see an ulcer, right? You can share either in the chat box or in the question answer box. Right? There is some blackish thing coming here. So this is a diagnosed case of myeloma. Now, would it help you? So this is basically cryoglobulinemia associated with myeloma, and this patient improved dramatically with a monoclonal antibody we use, which is daratumumab and TCD38. This is another patient who had this non-healing ulcer. So don't be biased by paraproteinemia, hyperviscosity syndrome, JN, thank you. Vasculitis, yeah. For this case, you want to comment anything? Non-healing ulcer. I'll give you another clue. Anyone? See, otherwise, when we present on Zoom, it seems that people are sleeping. So I want to keep you awake. I don't know. The slide is not moving. So this has IgA kappa. Does that help you? Let me see the answer box once again. Venous ulcer. Yeah, that's a good thing. This was also associated with IgA kappa vasculitis, as was mentioned for the previous. And once the clone was taken care of, this ulcer healed. Okay. So now I'll go to the next case. somehow, yeah. What is this? Obviously, this is a Caucasian. We are brown and black, but you see certain redness here, right? Any idea? And you'd like to know what I got in the blood? IgG kappa. So this is another cutaneous lesion associated with monoclonal IgG kappa. What is this? The skin becoming lax, acquired, right? You can see the lax skin. And we got IgG lambda paraprotein in blood. Anyone can diagnose? So this has got nothing to do with hematology. Don't worry. It's all internal medicine. Okay, I'll tell you the answer later. Don't worry. Once we discuss the cases, it will be easier for you to pick them up. Then, do you see what has happened to the eyes? And what did we find in the blood of this patient? IgG kappa. Can you correlate IgG kappa in blood and whitish deposits, which, if you look at D here, it has actually improved. So let me check the box once again. If someone has correlated, yeah, that was Pseudoxanthoma elasticum, obviously, but it's a monoclonal gammopathy of clinical significance. But what about the eyes? These eyes, anyone? You have IgG kappa, right? Okay. Those were actually light chain deposition. Okay. So patient did not have plasmacytosis. I'll come back to it later. What is happening? This is another Caucasian. What are these lesions? Patient also had fever. Patient had joint pain. And when we examined the blood, we found IgM kappa. Any guesses? Any of the students? Exfoliative glaucoma? No, that was a deposition. This is not palpable purpura. This is urticaria. And this is a syndrome. I know PGTs love syndromes, right? For their MCQs, they love the footnotes. So I've given a syndrome, which is a paraproteinemia. Does that help you? Okay, I'll go and give you the diagnosis now. So this is Schnitzel syndrome. So this lady had looked at the symptoms, and this is Lipsker criteria. So you have articarial rash and monoclonal IgM. Okay, so this patient has IgM kappa, at least two of the following criteria, like fever, arthralgia, arthritis, bone pain, palpable lymph nodes, hepatosplenomegaly, ESR high. It can be like any other vasculitis, and there will be abnormal findings on bone morphology. So you'd be surprised to know that these also are paraproteinemias, and they usually present to the dermatologist. So before going to what the paraproteinemias are, just a bit of physiology and pathology. This is the immunoglobulin molecule structure. As you know, you have a variable region and you have a fixed region, and this is the FC. This is the antigen binding, and this is the hinge, right? And this is the variable region. This is the constant region. This is the light chain. Madhuchandati was alluding to free light chain assay. So we can detect even free. And free light chain assay is a technology because, you know, if you just send antibodies, they will bind and they will form the heavy chain and light chain. So it actually looks at the free light chains by masking the site for binding with immunoglobulins. So serum protein electrophoresis is an age-old methodology, and you know what we do is just like hemoglobin electrophoresis, we pass electric current, and depending on their charge and their molecule, you get this type of a pattern. And if you want to remember it, you just hold your hand like this. So the little finger is albumin, then you have alpha 1, alpha 2, beta. These are small. And then the thumb is like gamma. So this is the normal pattern. In nephrotic syndrome, you'll suddenly see alpha 2 going up. Polyclonal, this kind of a thing comes. Protein wasting, everything goes low. And this is monoclonal gammopathy or paraproteinemia, right? So always look at the curve. There are certain laboratories in the city of Kolkata who give a report of serum protein electrophoresis without giving the curve. Do not accept it throughout your professional life, right? Now, what are the tools for looking at the M band? Electrophoresis I have already alluded to. It can also be capillary electrophoresis or gel electrophoresis. And then we do something called immunofixation. So when you see a peak like this, you will suspect that it's monoclonal. But how do you know it is monoclonal? So you use monoclonal antibodies and stain them. If it's a clear stain, then it's a monoclonal. If it is positive for both kappa, lambda, and maybe IgG, IgM, then it is polyclonal. So remember, you can suspect a monoclonal band on serum protein electrophoresis, but to confirm it, you need immunofixation. Now, free light chain assay is a very interesting story. Again, Mayo Clinic, they have a biobank where they had stored all the samples. As you know, Robert Kyle was working there. And they went on later, they discovered this, which was called free light. It has gone out of patent this year. And they saw that it predates the development of a monoclonal band. I will show you the timeline. You can also do the immunoglobulin levels by nephelometry. So, you know, globulin can be high in Kala-Azar. In Kala-Azar, the bone marrow can show you up to 20% plasma cells. But in Kala-Azar, all the three, or at least two of the three immunoglobulin levels are high. What happens when there's a monoclonal gammopathy? If it's IgG, then IgG would be high, the others would be subnormal. So we call it paresis of the others, and that is how you can confirm the same what you're doing by immunofixation. Sometimes you find that you're not getting it in blood. You can do a urine, 24 hours urine, protein electrophoresis and immunofixation. You can use the same instrument and you can understand where there is a monoclonal protein being leaked by the kidneys because of the high protein load. And this is the latest called MassFix. Again, mainly being patented by the Mayo Group. MALDI-TOF, so time of frequency, time lapse basically. But India now has a patent developed at Adyar Medical Center, acetonitrile phenotype. So it's not a standard of care, but it has an even higher sensitivity than your serum-free light chains. So if you have to do a screening panel, if you want to save money, you can just do a serum protein electrophoresis and a free light chain. In myeloma, it is 100% sensitivity. In Waldenstrom, which is IgM, it is 100%. In AL amyloidosis, it is 96%. In smoldering myeloma also, it is above 98%, that is 99%. But in MGUS, it is a bit low, 89%. And that is where your proteomic tools like MALDI-TOF help, right? So this is the sensitivity. And as I was telling you, when they went back 16 years prior to the diagnosis, when the electrophoresis was normal, look at the abnormal serum-free light chain ratio. Now, a bit of physiology about free light chains. Normally, they roam about, right? But they are actually, the limits are maintained by the kidney. So any patient of chronic kidney disease due to whatever cause, maybe diabetic nephropathy or others, you will see that both the kappa and the lambda actually are high. But the ratio is not that high. In monoclonal gammopathy, what happens is either the kappa goes up or the lambda goes up. So here is one diagnostic criteria where you have a value which is lower than 1 and above 1. And what is that normal value? It is 0.26 to 1.65. And remember, this is in normal kidney function. In abnormal kidney function, it is higher. We are trying to standardize it. So, if you look at in the real world, symptomatic myeloma, 96 of the patients have an abnormal FLC. If it's a light chain, 100%. But in MGUS, if you do FLC alone, only 33% show abnormal. So that's why we say, as a screening tool, you at least have to add either electrophoresis or immunofixation. And this is the mass effects, which does, it has a liquid handler, it has laboratory information, automated multi-spotter. This is the spectrophotometer, and this is the software which can detect it. All the basic science institutes already have this platform. So anyone wants to do a dissertation to look at it, they can collaborate with the basic science institutes. So this is paraproteinemia. Now let me come to my patient. This is patient number 1, has a significant M spike. You can see it, right? 44 grams per liter. On immunofixation, distinct bands at IgG and kappa, right? And if you look here, IgG is high, IgA is low, IgM is low. And if you look at nephelometry or free light chain otherwise, so you'll see IgG kappa is high, and the free light chain ratio, because kappa is high, it is 656. As I told you, the normal value is 0.26. And if you do mass spectrometry, there also you see that there is a IgG kappa peak, right? So sometimes you do not need to do all the tests, though the American guidelines recommend all. But if you find a peak and you know it's monoclonal, obviously you will not need mass spectrophotometry. Serum free light chain assay, if the patient can't afford upfront, we do it for monitoring. So now, this is the IMWG criteria. You all knew that it was previously CRAB, right? Hypercalcemia, renal insufficiency, anemia, and bone lesions, right? Now, what has changed is the technologies. So now to have a bone lesion, X-rays are not enough. You either have to do a low dose CT or a whole body MRI or PET CT, right? And now we have converted this CRAB into a slim CRAB. Now, what does that mean? That means that if the FLC ratio is more than 100, right? Or the clonal plasma cells are more than 60%, or if there is more than one focal lesion on MRI, which is at least 5 millimeter in size, then you do not need 10% clonal bone marrow plasma cells. Okay? You do not need this. You can straight away tell that this is myeloma, you need to treat it. You do not even need CRAB. All these 4 can be normal, but if this is abnormal, we call it slim, then it is a case of myeloma. Okay? So, there are other symptomatology in the clinics which will raise your suspicion. So, if there are recurrent infections, you should look. If there is constipation, poor appetite, rule out hypercalcemia, increased thirst. Especially the problem is if you have a diabetic who has nephropathy, suddenly the proteinuria increases and the creatinine starts rising. And you think, oh, this is diabetic nephropathy. Diabetic nephropathy does not have a delta curve like this, right? It usually is something like this. And increased fractures and bone pain, These are classical examples. Patient can present to the ER with disorientation, abdominal pain due to hypercalcemia. Now, as Madhuchandadi was telling you, there's a spectrum. The spectrum starts with MGUS, then smoldering myeloma, and then frank multiple myeloma, right? Now, MGUS means that you have a monoclonal protein, but you do not have 10% plasma cells and you do not have any CRAP or end organ damage, which we call ROTI. So, in the MGUS, it can be IgG MGUS, non-IgG MGUS, which can include IgM MGUS, and light chain MGUS, right? So all these have been given so that we can objectivize the disease. This is from the International Myeloma Working Group 2019, where most of the specialists are actually Indian Americans. So even the president of International Myeloma Society is Vincent Rajkumar. So myeloma specialists in US are all Indians. Anyway, so plasma cells will be less than 10%. Urinary monoclonal protein will be less than 500. FLC ratio will be abnormal. So when you detect a paraprotein or say a monoclonal gammopathy, that does not mean myeloma. That can even be MGUS. That can even be smoldering. So monoclonal gammopathy is a biochemical finding, right? And then if you do not find anything, we call it MGUS, but that shows our, it's same like idiopathic, because it is idiotic for us, pathetic for the patient. So we actually did not know the significance. So we used to call it undetermined significance. And we have now understood that actually a better name, this is one of the experts telling it, this was published in Blood 2016, it is actually a mysterious gammopathy of unexplored significance. So that's where the clinician comes in. Even, if you are screening in a community, Madhuchandadi told you 3.4%. Sorry. Yeah. And in certain villages in Maharashtra, we have found 4.2%. So anyway, we are exploring it. Remember that the clinical picture is very, very important. Now I'll discuss a case and you have to help me in diagnosing it. 53-year-old man with a past medical history of gout and uric acid nephrolithiasis was referred for evaluation of proteinuria and chronic kidney disease, right? Creatinine had been 1.5 to 1.8 for the last 3 years. Urine dipstick positive for blood and protein, which had been attributed to nephrolithiasis. Okay, so nephrologist was then referred to for evaluation of the CKD. Urine analysis showed 3+ protein, moderate blood, urine microscopic revealed many dysmorphic RBCs per high power field, but there were no RBC casts. Any idea what is going on? Then I'll tell you what the investigation showed. With this clinical history, what will you suspect as a physician? I'll wait for 30 seconds. I'm looking at the question answer box. Yes, I think someone is coming. Let me check. Renal stone. Oh, someone says again. Now this JN is very good at paraproteinemias. Last time also gave a correct answer and now has said it's monoclonal gammopathy of renal significance. Okay, let me see what came out, right? So let me go back. The urine protein to creatinine ratio was 3000 milligram per gram. Serum albumin was 4.1. Serum protein electrophoresis showed a small monoclonal spike, IgG kappa, right? So it's a monoclonal gammopathy, okay? Serum free light chain showed a free kappa of 17.5 and the ratio was normal. So I told you serum free light chain ratio is more sensitive than protein electrophoresis. You're getting a band in protein electrophoresis. You're getting it on immunofixation. You're not getting it on free light chain. Can anyone explain that? Maybe I'll wait for 10 seconds for the answer. Glomerulonephritis? No. So remember, in 10% of cases, you can have normal. I showed you while I was showing you myeloma, right? So hemoglobin was normal, calcium was normal in spite of CKD. So what is the most appropriate next step in management? You can just type A, B, C, D, E. I need at least 2 persons to contribute just to prove that you're not sleeping. What will you do now? A, okay. This is JN who had suspected MGRS, so he's consistent. He or she, I don't know. Anyway, would you like to do a bone marrow biopsy? Question answers. A. Most of you are answering A. Okay. So now let me tell you what was done to the patient. He underwent a kidney biopsy. Now let me tell you the challenge here, and you will all face it. Sometimes these people already have underlying kidney disease. The kidney is shrunken, and the nephrologists say kidney biopsy cannot be done. But those who know how bad MGRS is, they will swear on a renal biopsy, and I'll show you the reason after some time. And this was the kidney biopsy, which showed proliferative glomerulonephritis with monoclonal IgG3 kappa deposits with moderate interstitial fibrosis. Now, if you're not doing the kidney biopsy, then how will you diagnose it, right? So he was then referred to hematology. He was labeled as MGRS. He was referred to us for evaluation of an underlying clonal cell disorder. We did a bone marrow, and this is kappa, showing kappa restricted clonal plasma cell population. But as luck would have it, 5% to 9% plasma cells. Now, if you highly believe in semantics, that says 10%. But if these plasma cells are clonal, we do not bother for the percentage. This is a clonal disease. Skeletal survey was negative for lytic lesions. So now tell me what should be the next case, next step in management. Fast fingers, please. Tell me, what would you like to do? I think one answer is coming. Shaurabh Pal says, no, this was the previous answer. No, B, A, B. So there are some who feel A, some who feel B. Let me tell you, once you diagnose that there is a kidney disease, you have to treat it. You cannot follow it up. This is not MGUS. So this is MGRS. So you will treat, and bortezomib is kidney friendly. So you can treat with a bortezomib based regime. That can take care of your glomerulonephritis. So we use cyclophosphamide, bortezomib, dexamethasone. We call it CyBUT-D. At the end of his treatment, creatinine did not rise. Proteinuria had decreased from thousands to 98. Serum electrophoresis protein showed a detectable monoclonal spike, but it was below the limit of quantification. Free light chain was normal earlier, it was still normal, right? But the saga continued. Again, his proteinuria started to increase. A repeat kidney biopsy again revealed the same disease, for proliferative glomerulonephritis with IgG3 kappa deposits. Again, we tried because the relapse was late with CyBUT-D, but this time we could not use cyclophosphamide because of alkylating toxicity. Second treatment was well tolerated. Again, he went into remission. So this was the first publication when they said that when MGUS is no longer undetermined or insignificant. So let me give you the clinical clues. And MGUS, the chance of transforming into myeloma, remember, is 1% per year. Here, by 20 years, most of the people die. That's why it is so important, even if you're not specializing in nephrology, that you should look for MGRs. There's a beautiful consensus statement which was published in 2019 of the International Kidney. So basically, monoclonal gammopathy of renal significance is a clonal proliferative disorder that produces a nephrotoxic monoclonal immunoglobulin, right? Does not meet previously defined hematological criteria for treatment of a specific malignancy, be it lymphoma, myeloma, because B-cell clonal disorders can also give rise. I have such patients. But the diagnosis is established by kidney biopsy and immunofluorescence studies. Monotypic immunoglobulin deposits, they might be minimal in C3 glomerulopathy or in thrombotic microangiopathy. So remember, MGRS itself is not one disease. I do not want to confuse you, but it is basically a B cell or plasma cell clonal lymphoproliferation with one or more kidney lesions that are related to the monoclonal immunoglobulin, and the underlying B cell or plasma cell clone is not significant. So we can't detect it. It is not causing a tumor. It is not fulfilling the current criteria even for myeloma, right? This is what MGRS is. So basically abnormal urinary findings plus renal biopsy, light microscopy, electron microscopy, looking for the monoclonal protein and then looking for the clonal cells. That is where we come in, right? And these are some of the diseases, right? So it's not a single kidney disease. So the usual associated are based on whether they are non-organized or organized. You need a very good nephropathologist. And the organizations can be fibrillar, immunotactoid, crystalline. Don't worry, I'll show you some beautiful pictures. And this is where they can hit. So depending on where they deposit it and what is the inflammatory reaction, you can even have IgG-related amyloidosis. You can have immunoglobulin deposition disorders, and you can have light chain disorders, immunotactoid glomerulonephritis. So obviously this is in the domain of nepropathologist, but remember as a clinician that it can destroy the kidney and it's a reversible disease. So I'm not going into histopathologic pictures and all. Where is kidney biopsy recommended? Those with monoclonal gammopathy and unexplained kidney disease, right? There might not be fractures, there might not be hypercalcemia, there might not be anemia. Those with known risk factors for chronic kidney disease, I think, yeah, thank you. Atypical clinical codes, like I was telling you, the proteinuria was something like this going on. Suddenly it goes like this. Or the creatinine was like this, suddenly going on like this. That is the candidate for kidney biopsy. And any young person less than 50 years who has kidney disease and monoclonal gammopathy, even if the kidney disease can be explained by the monoclonal gammopathy, even to look at cast nephropathy, a kidney biopsy should be done, right? I'm not going into the other things. So what to do in 2024? Possible MGRS, AKI stage 3, biopsy advised, EGFR less than 60. When will you defer the biopsy? If the urine analysis is bland, there is no evidence of light chain proteinuria, or the EGFR is stable. So most of the people will go actually through this care pathway. And then depending on what they have, light chain restriction, heavy chain restriction, you can diagnose the entire disease. There's a beautiful review. You can read it. So the aims are to treat the clone, treat the renal disease, prevent nephrotoxic drugs, but keep on assessing the hematological response. As I told you, it's a basket. Even cryoglobulinias can present with MGRs. Now I come to the bigger daddy, right? From which MGRS came out. Now you have MGRS, you have MGSS. This is the patients I showed you in the beginning, right? Including Schindler syndrome and cutis lacta and light chain deposits on the eyes. So skin diseases, there can be multiple. You can have malignant plasma cell neoplasm, myeloma, like Waldenstrom, AL amyloidosis, cryoglobulinemia, OM syndrome, who has cutaneous manifestation, non-malignant high association. I showed you, necrobiotic xanthogranuloma, the peri-orbital, Schindler syndrome I have shown you, non-malignant association, pyoderma gangrenosum, Sweet syndrome, leukocytoclastic vasculitis, unknown. We do not know why they happen. Erythema electrovitum, diutinum, subcorneal. So, there can be miscellaneous cutaneous disorders. And your monoclonal gammopathy or paraproteinemic patient can present to the skin OPD. And then you can have purpura pruritus infection. Obviously, that can be due to the disease or due to your drugs. Then comes monoclonal gammopathy of clinical significance. Now people thought if skin is involved, kidney is involved, can other systems be involved? So this is how science progresses, right? So then ophthalmologic significance, I've shown you the picture. So this is the timeline, how it came. Poem syndrome has been there before we joined medical college. Schindler syndrome has been there since 1972. Canomed syndrome came later. So first was MGUS, MGRS, MGSS, MGCS, MGOS. And now you also have MGNS, neuropathy syndrome. I'll discuss them also. So whenever I speak on M-band, people think I'll be discussing only myeloma. But actually the spectrum is huge. If you look at this, MGUS can progress to smoldering, can progress to frank myeloma. There can be an overlap with AL amyloidosis and Waldenstrom. So you can have IgM MGUS. And these prevalences are different, right? So if you are checking your WhatsApp and seeing what your friends are sending you, just dedicate 60 seconds to this slide. Remember, MGUS is just a finding. There can be multiple diseases associated with it. The tumor might progress. You can go from low risk MGUS to intermediate and high risk. High risk, there are several scoring systems. Due to lack of time, I will not discuss all that. Then low risk smoldering myeloma, high risk smoldering myeloma, high risk smoldering myeloma. There are now indications to treat them. And then, we have made slim crabs so that high risk smoldering myeloma come into active myeloma. Still, myeloma, the plasma cells are still in the bone marrow. So I call them as this is the chichkechor. These are then the thieves. And these are the dons, mafia, but they still need the politicians. So marrow is their microenvironment. But then when these mafia dons themselves become politicians, what do you get? You get extramedullary myeloma and plasma cell leukemia, right? You do not need your microenvironment. But this is one part, right? So this is one part of the spectrum where the tumor is progressing, and we are quite aware of this. But the monoclonal protein themselves can destroy the kidney, can lead to amyloidosis, and can lead to MGCS, MGSS, MGNS, MGOS. If this picture is there in your brain, the eyes cannot see what the mind does not know. So remember this. Amyloidosis, as we have more proteomic tools, we now know that other than amyloid, light chain amyloidosis, which can be associated with multiple myeloma, others are in a class apart. We are trying to treat them, but only this is amenable to treatment. The treatment is just like myeloma, so a proteasome inhibitor and thalidomide. So why do we see so many diseases? What happens? Within the tumor, there is inter and intracranial heterogeneity, and there is genomic instability. There might be a primary mutation, then there is a big bang or a driver mutation. And the microenvironment, as I explained to you, like the politicians, they actually provide growth restricting and growth permissive signals, which ultimately determine, because all MGUS do not turn into myeloma, 1% per year. But all myeloma must have gone through this phase, and they must, have failed to diagnose. In India, most of the patients present here to us, right? So depending on how the deposits are, where the deposits are, we try to classify. There is also mixed cryoglobulinemia, xanthomatosis, cold agglutinin disease, peripheral neuropathy. I'll just tell you what to do, because then the patient becomes a ping pong between the neurologist and the hematologist. The neurologist says he will treat the M band and you'll get okay. Unfortunately, that is not the case anyway. So if you are still confused, remember you have normal persons, you have transient MGUS persons, and then all these monoclonal gammopathies who can go either to amyloidosis or smoldering or plasma cell or myeloma, right? And all these monoclonal gammopathies of clinical significance, this is a beautiful thing to show you that depending on Poem syndrome, the clinician is more important. But in Schindler's syndrome, the pathologist is more important. What does that teach you? There should be regular crosstalk between the clinician and the pathologist. I've given the reference. This is a free article. You can look at it and understand. So depending on what organ is affected, again, it depends whether the clinician diagnoses it first or the pathologist diagnoses it first. In systemic amyloidosis, kidney, skin, lung, heart are affected, so both can do it. But in cryoglobulinemia, clinician should take the upper hand, right? In Tempe syndrome, clinician. But in certain cases, like MGRS, kidney biopsy person is most important. Remember, when you are seeing a monoclonal gammopathy, the patient can be here or can be here, right? So you have to keep your eyes and ears open. There are certain known translocations. Interestingly, the translocations which are bad prognostic factors in myeloma can be present even during MGUS, right? So that doesn't prove anything. So I hope I have not confused you. This is the algorithm. If the globulin is high, or if the patient has back pain, unexplained anemia, unexplained kidney disease, you request at least serum immunoglobulins and electrophoresis, which is the cheapest option. Measure IgG, IgA, IgM. If all are high, chronic liver disease and inflammatory conditions. All are low, possible congenital immunodeficiency, refer to immunologist. In the electrophoresis, if a band is identified, then as I told you, if it is IgA paraprotein but less than 15, small band, you should repeat in 3 to 4 months. But if it is IgG or IgA more than 15, or urine shows free kappa or lambda band, or serum free light chain is normal, then look for end organ damage, take a decision. If required, you take our help. If you're suspecting MGRS, one thing you remember, convince the nephrologist or the interventional radiologist to do a kidney biopsy. Now, this interesting part, BIN, right? Keep on referring patients to us. Working for CIDP, they get a monoclonal paraprotein. Others have to be ruled out. If there's a paraprotein, if it's non-IgM paraprotein, rule out POEMS and AL amyloidosis. If it's an IgM, then it can be an IgM MGUS neuropathy or MGNS, where anti-MAG antibodies are found in 50% of cases, but they are not linked to symptoms, mainly demyelinating neuropathy. The treatment is not like myeloma. It is steroids, IVIG, or rituximab. Skin lesions. Evidence of monoclonal gammopathies and diseases ruled out. Skin biopsy. If you can't find anything there, then you can suspect the other rare diseases. And if you're not confident, refer it to a dermatologist. But tell the dermatologist that you're suspecting a monoclonal gammopathy associated disease, because they also might not know. So if I look at monoclonal gammopathy of undetermined significance, there are more than 350 associations. Cancers are myeloma, Waldenstrom, plasmacytoma, amyloidosis, light chain deposition disease, cryoglobulinemia, which are not malignancies, as I showed that spectrum. Associations can be neuropathy, proliferative glomerulopathy, skin disorders, fractures. Most patients of rheumatoid arthritis have a monoclonal protein. So for a clinician, remember, paraproteinemia, M-band does not mean myeloma or Waldenstrom if it's IgM. Myeloma can be present with paraproteinemia if they are non-secretory. So either way, do not stop there. If you detect a paraproteinemia, whatever it is, even a light chain, look for end organ damage. For light chain, especially look at the kidney. Before labeling a person as MGUS, please rule out amyloidosis. You can do an NT-proBNP, or you can do a highly specific echocardiography to look at the spectral pattern. A multidisciplinary approach helps, right? We all cannot remember all these things. So the suspicion is the most important thing. I hope I have not confused you more. Just showed you the picture of where a simple paraprotein can lead the patient to. Thank you very much. Chairperson koi? Always. Yeah.
No question.
বলো
না কোয়েশ্চেন হচ্ছে প্রান্তর,
বলুন।
হ্যালো শুনতে পাচ্ছিস? হ্যাঁ,
আমি শুনতে পাচ্ছি। আমি 1 মিনিট, আমি চার্জারটা লাগিয়ে নিই। হ্যাঁ, চার্জটা কমে গেছে। জাস্ট 1 সেকেন্ড। 1 মিনিট।
practical question is that MGUS তো প্রায়ই পাচ্ছে because doctors feel any monoclonal gammopathy is myeloma. So they don't know what to do. So how do they follow up these patients?
Yes.
What is the algorithmic approach to
Yes.
MGUS over
Yeah.
the years?
So I intentionally did not go into that because that is a bit complicated. But let me tell you, for the students, IgG MGUS is better, where we usually follow up. If you're not doing any scoring or anything, all the scores algorithms are there on the net. We usually follow up every 6 months, but we only do not measure the monoclonal protein. We look at creatinine, we look at a complete blood count, we look at calcium. If there is no heart involvement, then we do not do it every 6 months. For certain IgM diseases, initially we do it for 3 months. If it's a plateau, then later on we follow them every 6 months. So IgG, we follow them every 6 months. If it is a plateau for 1 year, then every year. This is what is followed at the Mayo Clinic, and I think that this is what we follow also here.
So Prantar, why couldn't you be a Robert Kyle of NRS Medical College, getting all the archived blood samples and finding out what is the prevalence of monoclonal gammopathy in the population of India, especially in West Bengal. I think that would have been very important.
Yes, so I'll tell you, we have a society called IMAGE, Indian Myeloma Academic Group. It has already tested 40,000 samples, and in my village cohort where I stay now in Tamil Nadu, I am starting screening for monoclonal gammopathy also. So maybe in another 2 years, and this is being, we are also using LCMS, which has the highest sensitivity to look at the population, because it is very important. Why I couldn't do it in NRS is because if your OPD is full of iron deficiency anemia, when can you go to the community and do the work? And you need good basic scientists to take it forward. Anyway, so let me tell you, we have a plan of following them up for 15 years, and the fund is already available. So we are doing it in villages, Maharashtra, Madhya Pradesh, near Haryana, and south in Tamil Nadu. So maybe 3 years down the line, I'll be able to tell you the prevalence. But what we see on follow-up, that will take us at least 8 to 10 years. Because it's 1% per year according to their data. We have to see what is our data.
Good. So that's very exciting. Maybe it will not be there, but some data will come
I
out.
will also not be there, don't worry. But the youngsters are enthused about doing this work. That's the best part. Shivendra has 2 questions.
Yes.
Role of thalidomide. So thalidomide is used in myeloma, especially, we now what we do is, Americans say 4 drug initially, but the 4th drug does not have a biosimilar. It is very expensive. So if someone can tolerate and the frailty index is low, we start off with a proteasome inhibitor, which is bortezomib, and then obviously an immunomodulator, that is lenalidomide and dexamethasone. But in chronic kidney disease, patient presenting with renal failure, lenalidomide has high toxicity. So we used initially, the patient, as I showed you in MGRS also, we used bortezomib, cyclophosphamide, dexamethasone. Now we have replaced cyclophosphamide with thalidomide because the efficacy is a bit more. So thalidomide is also nephrosafe. It is already there, but we do not treat smoldering myeloma unless it is high risk. We do not treat MGUS. Then second question is zoledronic acid in severe bone pain. Let me tell you, other than severe bone pain, in most of the patients, we are using zoledronic acid. Only thing is that we look for kidney damage already. There you can use denosumab, but it is prohibitively expensive. And the other thing is, if there is some teeth problem, there can be osteonecrosis of the jaw. So we tell the oral surgeons, if you are extracting a tooth or something, let us know. We do not give zoledronate for 3 months. Vaccines in myeloma. Work is going on and it is being headed by Nikhil Munshi and also at the Dana-Farber. I think phase 1 will start in 24 end or 25. So other than vaccines, let me tell you, and I was in Mumbai for 2 days, already CAR T therapy has been approved for myeloma. It's another thing that it is expensive, but in India, we have already licensed the first CAR T from IIT Bombay and Tata Memorial Hospital, but not for myeloma. We are using it for lymphoma. So the concept of CAR T is very clear. You take out those cells from the patient and then you teach the T cells and then you use a biogenerator, amplify it, and then infuse it back. So CAR T can be used if all the drugs are exhausted. We also have certain BiTE antibodies, which are bispecific. So CD19 with CD138, tagged with a T cell. So we are trying all sorts of immunotherapy, which all can be called vaccines in some form.
Prantar, with the advent of shingles vaccine, we're using acyclovir as the prophylactic in all these patients.
Yeah.
So still, if we have a vaccine for shingles, do we continue the acyclovir or
Yes,
do
and
not?
let me tell you that, I was also mistaken. I usually use 400 milligram twice or thrice daily, right? But that can only prevent herpes what is the other one? Sorry. Matlab, it doesn't prevent herpes zoster. Okay. So the dose for herpes zoster prophylaxis is actually 800 milligram thrice daily, which most of our patients can't tolerate. I remember MSD was supposed to do a trial for shingles vaccine for myeloma patients. That product, I think, will come to India. When that comes, that will be easier for us. But we definitely immunize against pneumococcus and every year influenza vaccine. Yes, there's a question on solitary plasmacytoma. Yeah, that's a very good question. For solitary plasmacytoma detected on imaging, first rule out whether it's a single lesion or a multiple lesion. Single lesion can still be managed with radiotherapy. This is one of the few cases where radiotherapy still has its role. But if you find that there is already a monoclonal protein, and ideally with a high sensitive, then you can straight away start systemic therapy. Valganciclovir, yes, it is approved for herpes zoster prophylaxis, but it is more expensive. And how do you monitor? Okay, if you don't get it, the monitoring is similar to how we monitor MGUS. But here, imaging will form a part at least once a year, and that imaging should be either low dose CT or whole body MRI. But in Kolkata and most of the cities, the easiest examination here is a PET CT. But it can miss 30% of the lesions because there can be lytic lesions.
So, regarding PET CT versus whole body MRI,
Yeah.
your
See, the guidelines say whole body MRI is better.
okay. So, are you doing whole body MRI commonly or PET commonly?
No, commonly I cannot do because most of the scan centers do not do it.
My question is regarding 3-monthly zoledronic acid, since there is a chance of nephrotoxicity, and
Yes.
in oncology, we are very commonly using 3-monthly zoledronic. So, what is your take in myeloma?
Yeah, in myeloma also, after 12 doses, that means 12 months, we also shift to 3-monthly, but we do not go over 18 to 20 doses.
So,
That is our recommendation.
maximum you're giving, not
Yeah,
beyond.
maximum 20 doses. But if there is a late relapse, sometimes, and if there is bone pain, then again we use.
What is your take on the tolerability of lenalidomide in our population? Ideal dose.
Yeah, so let me tell you, this time also Vincent Rajkumar, Shaji, all were there. They all have accepted that in Indians you cannot go above 15, and most of the Indians tolerate only 10. So they have clearly told that, based on our feedback, do not try above 15. Never try 25, except, if you have a heavily built person with a high BMI, height of close to, 6 feet. So no need. And it has been shown that if you're using 10 and if there is a slight increase, shifting to 15 also does not help, but the tolerance decreases.
So what is your cutoff for creatinine or creatinine clearance where you use lenalidomide, beyond which you don't use? Because thalidomide is not very commonly used, as you know, except
Yeah,
in...
I know. But, looking at the data and everything, so if GFR is less than 30, I do not use lenalidomide. Either cyclophosphamide or thalidomide.
Okay.
And for the PGTs, let me tell you that you cannot reverse diabetic nephropathy. But if you can diagnose myeloma within 6 weeks of onset of nephropathy, it is totally reversible. Madhuchandadi will know, I know, so many patients who were on thrice weekly dialysis, they have a normal kidney function now. So diagnosing it early, having a low threshold to suspect myeloma is very important.
I think the message is that multiple myeloma is a disease where care continuum is available.
Yeah.
If you fail, you go to the other. So you don't give up hope.
Yes.
You continue treating the patients and they will have a reasonable quality of life.
Yeah.
So the last question, I think that cystatin level to predict?
Myeloma kidney. Yeah, so there have been certain studies, but it is not a standard of care. And cure of myeloma, let me tell you, till to date, myeloma is an incurable disease. There are certain trials going on upfront bispecific antibodies in smoldering myeloma. You know, Vincent is doing one such study. They're thinking that, you know, why should we wait? We should give it early and get cure. But so there are four things. One might be that we are not being able to diagnose it early. That's why we are not being able to cure it. Or the way we are using the drugs, we are not able to cure it. But the thing remains is, till to date, myeloma is an incurable disease. But if it's not a very high risk disease, the first remission, the recurrence-free survival could be as long as 7 to 10 years. And another thing which I have not discussed and people should understand is autologous transplant with high dose melphalan is still a standard of care in a country like India, because, you know, one dose of daratumumab costs 1.4 lakhs. Even in the private setup, you can do an autologous transplant for 8 lakh rupees one time. Daratumumab once weekly for 8 weeks, once fortnightly for 8 weeks, and then once a month, right? So there are European studies which say, okay, you can do myeloma when the patient relapses. In Indians, the first chance is the best chance. If a patient is fit for transplant, definitely go in for autologous transplant with high dose melphalan. Yeah. Reversal of heart. Shivenda will do that. There are clinical trials, Shivenda, but we have not reached. It's not an exciting, but let me give you an exciting news. Our in myeloma academic group now has an amyloidosis chapter. I'll send you the link. You can become a member, and they are doing certain interesting work on that.
So I think, Prantar, we must highlight to postgraduates and to physicians that
Yes.
supportive care is very, very important in myeloma.
Absolutely. And
So
you know,
do not think myeloma is only a hemato-oncological perspective. Supportive care is so very important that physicians must be a part of this support group.
Absolutely. Multidisciplinary, and physicians should know that when they get fever, you know, they should be started on antibiotics because of the disease and the drugs. They are always immunosuppressed. Infections have killed so many people whose myeloma was in remission, right? So I think that is a very good message, and everyone, the myeloma patients are not untouchables, right? So everyone should have a look at them and we can give them a better life. Two prime ministers of India have died due to myeloma, right?
Yes.
Of how many prime ministers we had? 2 have died due to myeloma.
Yes. And 1 died due to infection in myeloma.
Yes.
So I think if there are no further questions, we had a very exciting and interactive discussion with Prantar that myeloma is not in isolation with hemato-oncology. It's part of the physician spectrum. First in diagnosis, early suspicion, and second is the treatment has many adverse events due to the drugs. So we must all be careful. And third is give supportive care immediately once you start thinking of multiple myeloma. So with these few words, over to the
No, yeah, Madhukanda, I have got a one. Can you allow me one line just to ask?
Yes, sure.
প্রান্তর, খুব তোমাকে অনেকদিন পরে দেখে খুব ভালো লাগলো।
থ্যাংক ইউ।
আর ব্যাপারটা হচ্ছে, আমি একটা জিনিস, তুমি একটা কমেন্ট করলে, এই মাইলোমা অ্যাসোসিয়েটেড নিউরোপ্যাথি একটা কথা বললে না? মনোক্লোনাল গামাপতি অ্যাসোসিয়েটেড উইথ নিউরোপ্যাথি। নিউরোলজিস্টরা জেনারেলি পেশেন্ট না রেখে আবার হিমাটোলজিস্টের কাছে পাঠিয়ে দেয়।
হ্যাঁ, পাঠায়।
এটা বললে তো? Primarily, আমার মনে হয়, if we have a diabetes and the patient has got a diabetic peripheral neuropathy, but we try to control the diabetic, because as such, there is only symptomatic treatment for diabetic peripheral neuropathy.
Absolutely.
Don't have much. But do you think, is there any role for, on the part of the neurologist, is there any role for us to keep the patient with us or to send back to the hematologist for stem cell transplantation or gene therapy and rituximab?
Stem cell transplantation এ লাভ হবে না দাদা। The most important thing is, if you get an M-band, you can take an opinion, as I told you, if it's IgM, right? then there is a chance there is a problem. Otherwise, just like a monoclonal protein in other diseases, we do not know, and we need you more than you need us because the nerve biopsy helps. Sometimes you'll get amyloidosis on the biopsy. Right? So that's why we want them to stay with you.
Thank you.
Hello, Prantar.
হ্যাঁ
আমি ডক্টর এস.বি. গাঙ্গুলি।
হ্যাঁ নমস্কার
I am not an epidemiologist, not a research worker, but a poor clinician.
হুম
So I will tell my few experience about multiple myeloma. In 1977, when I was intern, Professor Munjumitra, I saw a case of multiple myeloma with external ophthalmoplegia. So at that time, there is no answer. But I think now it is multiple myeloma with mononeuritis multiplex or multiple myeloma with ophthalmic syndrome.
yes
And second case, when I was in Arjigar, my intern's father from Jalpaiguri came with pyrexia of unknown origin. There is no pointing sign, only some sign in moving the tongue because it was very thick.
হুম
And his hemoglobin was low, below 10, and ESR above 100. So I performed the blood test immunophoresis, and it proved to be a multiple myeloma. Then I made a simple formula that when I will see a patient, whatever is complaint, whose hemoglobin is below 10 and ESR is 100, I will send the blood
Yeah.
for
Yeah,
for
at least
hemoglobin
electrophoresis, at least serum protein
electrophoresis.
electrophoresis.
Even in rheumatoid arthritis patient,
Hmm.
I sent many blood of rheumatoid arthritis patient, but none came positive.
Yeah.
Now the last case, when I was in KBC Medical College, then and at Changnok Hospital, Dr. Sagar Bose referred me a case of low back pain. His widow, her hemoglobin was 12, ESR was 30, and Z score and was below normal. And he was giving calcium and so I made a diagnosis of osteoporosis and changed him to zolandoic acid. Then COVID era came, only I was treating the patient over telephone.
Hmm.
Then after the COVID era, he came to me at my chamber, still having the pain, low back pain, albumin, hemoglobin is still 12, ESR is still normal, and non-albuminous protein is normal. But with a new complaint that pain at the scapula. Then I thought it must not be osteoporosis because pain in osteoporosis is very rare and it can't occur in multiple sites. I ordered hemoglobin, electrophoresis, and it proved to be a case of multiple myeloma. Now my question, have you ever seen any patient whose hemoglobin is normal, ESR normal, non-albuminous protein is normal, presented to be multiple myeloma? Because as C was normal, so it was not my formula to perform plasma electrophoresis. So I was befooled and diagnosed the case just 1 year after the patient came to me.
Yeah. So it can happen. That's why I say that people say globulin is normal, ESR is normal. See, these are surrogate markers when there is a lot of things happening. Our aim is to diagnose them early, right? So clinical index of suspicion is the most important thing. And let me tell you, osteoporosis is also a disease defining criteria for myeloma. So as I told you, obviously, when you do an MRI,
please repeat the last line.
the last line is that osteoporosis is also a disease defining criteria for myeloma.
Oh, achha, it is news to me.
Yeah,
I was
yeah.
not aware of
So
it.
if it is osteoporosis, but it's not looking like the typical one, we have a lot of problems. Sometimes we over investigate. But the beauty of myeloma is if you diagnose it, you treat it, there will be relief and the patient bone density will improve. Right? So, yeah.
So what I have learned from you that cryoglobulinemia is also a part of paraproteinemias.
Yeah. Absolutely. Both type 1, type 2,
type 3.
All those, these are all B cell clonal disorders.
We miss cryoglobulinemia.
Yes.
I am attending API clinical meeting almost regularly for last 32 years, but I have never seen in Calcutta anybody presenting a case of cryoglobulinemia because I think we don't think it.
Yeah. There are patients. Yeah.
There are patients, but we don't think it.
No, one patient was presented by in Calcutta Medical College by Moitri.
কবে?
মনে নেই, তবে আমি তখন ছিলাম মেডিকেল কলেজে মৈত্রীটা।
Then I missed it.
Now I request Dr. Rotindranath Sarkar, who is one of our course directors, to give vote of thanks.
Thank you, Amolda. It was really brainstorming. I couldn't connect in the initial stages, but the interactions were very good. So let me first thank Prantar for an excellent presentation, and as well as Madhuchanda for good interaction. And then I must thank all my PGTs who have joined, and also our fellow API members. And I now hand over this to Amolda.
Thank you for your vote of thanks. Now we are going to adjourn this master class. Our next master class will be on 18th of February, when we will have the master class on approach to myopathies. Here